Good evening, everyone. Today, I'm going to talk a topic about ERAS in colorectal surgeries anesthetic considerations. First of all, I'd like to thank Dr. Balavaskar sir and Dr. Srinivasulu sir for giving us an opportunity for the Institute to present in this academic meet. So let us go to the topic, ERAS in colorectal surgeries. So what is ERAS? ERAS is nothing but enhanced recovery after surgery or early recovery after surgery. So why this ERAS concept has come? Earlier, there was a traditional conventional care wherein the patient was undergoing the normal perioperative care, thorough preoperative evaluation, and the patient was discharged as early as possible. So the new concept of ERAS came into practice wherein the patient was taken care holistically and wherein there was a multidisciplinary approach from all the specialties of the medical field, wherein there was a prehabilitation, perioperative changes in some of the practices in the perioperative care, which led us to early recovery and discharge from the hospital. So, I'm going to talk about the topic on overview of following definitions. So, introduction. So, as I told earlier, ERAS is nothing but is a creative approach to perioperative management of patients who undergo major surgical procedures. It is also known as fast-track surgery. Earlier, this concept of ERAS was developed for colorectal surgeries, and over the period of time, it has been enhanced or it has been extrapolated to other specialties like urology, gynecology, head and neck, and orthopedic surgery. The concept was first developed in 1990 by Henry Kellett, who was a surgical gastroenterologist. So he just designed a protocol wherein there was an enhanced recovery by managing the entire course of care by altering the traditional best practices to optimize the better patient outcomes. So ERAS, as I told, is a multimodal perioperative care pathway designed to achieve early recovery for patients undergoing any major surgeries. It accelerates the patient recovery and reduces surgical stress response and supporting the normal physiological function. As you usually know that any surgery or anesthesia is nothing but a deviation from the normal physiological process, and this derangement will lead to increased delayed recovery or for the patient and or in terms of delayed wound healing or delayed return to normal function. So by putting some evidence-based practices, we are trying to accelerate or we are going to decrease the post-operative period of stay of the hospital and early recovery and do not alter the normal physiological function as late as possible. So ERAS represents a paramount shift in the perioperative care in two ways. So one, it re-examines the traditional practices, replacing with evidence-based practice, and it's comprehensive in its scopes. It covers all the areas of the patient journey whenever it comes to a surgical process. So any surgical intervention, we know that or anesthetic procedure itself can lead to an it's a sympathetic response where you can have a varied response of hormonal response, metabolic stress, especially a catabolic reaction, wherein there is a delayed or slow downs the recovery period. So the program was initially developed and promulgated for use in colorectal surgeries, I told earlier. And first it was started in colorectal, and then later on, when they found success and they did audit and the patient education was good and the outcomes were very good, so they tried, why could this not be tried in other surgical specialties of head and neck, orthopedics, or urological procedures? And recently it has been expanded to various subspecialties, as I told earlier. So let us go to a brief history. So as I told, it's a Danish professor by Henry Kellett, was initially adopted to manage undergoing colorectal surgeries. In 2000, ERAS collaboration was done in Europe with the 5 centers, mainly in Denmark, Norway, Sweden, and England. And in 2009, the Department of Health in England established an enhanced recovery program for selective surgical procedure in 4 specialties. So what does this program evaluate? One is the length of stay and readmission rates, improved patient experience, significant reduction in the length of the stay. So these are the parameters which they are going to measured during this program. And they found that with this invention or adoption of the new protocol, whatever that I told, the length of stay, the readmission rates, and your sorry. So readmission rates, improved patient experience, and significant reduction in length of stay were all decreased in the patients which were involved in enhanced recovery program. So in 2010, the ERAS Society was found in and headquarters in Sweden. And the mission of ERAS Society is to develop perioperative care, and to improve the recovery through research, audit, education, and implementation of evidence-based practice. So there is also a society called ERAS Society, which offers specific guidelines, so useful information, resources to related to enhance recovery. So this is the current or latest clinical practice guidelines of enhanced recovery, especially in the colorectal surgery, which was in 2022. The earlier one was in 2018, and due to some modifications and evidence-based practices, they have done some updation or changes in evidence practices or clinical practice guidelines, which have been very useful for colorectal surgeries. So what is new in 2022 in ERAS? So there were new recommendations there were some interventions which were changed throughout the period, intra and post-operative period, and some recommendations were updated starting from your pre-admission, pain management, fluid control, and post-operative management. So let us discuss this in detail about each and everything, what are the changes that have happened in 2022 guidelines. So what are the components of enhanced ERAS? I told you, I start from the pre-surgical, pre-operative or pre-surgical period, and it goes through till the patient is discharged. So the pre-operative period, you need to have a patient education and counseling. Have to have a meeting with each and everyone, the surgeon, the physiotherapist, the nutritionist, the anesthetist, everything. So it gives a holistic approach. It gives an understanding to the patient of what he's going to undergo whenever he's going to have any colorectal surgeries. Carbohydrate drink, use of epidural pain controls, and during intraoperative, any modifications of your anesthetic procedure or drugs definitely will have an impact on the patient later in the course of the study. So judicious use of opioids, alternative modes of surgical access like laparoscopy or robotic surgeries, careful consideration of blood transfusions. So next, during the post-operative, early mobilization, early removal of NG tubes or urinary catheters, transition from IV to oral medications, and early allowance of food intake. So all these matters, and everything, whatever the interventions are going to take during intra and pre-operative period, definitely it will have an impact, and it will enhance the patient's recovery as early as possible, and it will lead to less hospital stay, less morbidity, and early recovery, early intention to retire any other modality of treatment like radiotherapy or chemotherapy in onco patients. So this is just another schematic revelation, whatever I told earlier. So what are the goals of ERAS? The goals of the ERAS includes reduction of stress response to surgery, acceleration of recovery, and reduction in the duration of the hospital. And ERAS, I told you, it's a multidisciplinary approach to perioperative care with specific emphasis on perioperative education, the most important thing. If you educate the patient and if he knows what exactly the things are going to do on each and specialty of or a consultant or expert is going to tell, if he follows that, if he understands that, it will be easy for us to and sail through the perioperative course. Pain management and early rehabilitation. So as I told, this early rehabilitation and pre-rehabilitation are the two important concepts in ERAS guidelines, particularly for patients who undergo laparoscopic and other colorectal procedures. So with this evidence-based practice, they found that the results were very positive, wherein they found that the reduction in the length of hospital stay and post-operative complications were 30 to 50% respectively. So I told it's a multidisciplinary approach of ERAS, wherein include all the specialties. It's not an individual effort, it's a team effort which makes the patient to sail through or lead to better recovery in the post-operative period. So why ERAS? So normally there was a conventional traditional care that was going on. So why they wanted to change over from normal conventional care to an ERAS, wherein they introduced new practices, evidence-based practices. So why this? So they found that the basic principle in ERAS was successfully delivering surgical care with minimum deviation from normal physiological function, as I told earlier. So it is better understood in terms of a graph. So I'll just go to the graph. So this is a graph where you can see here. So there was two graphs. One is on your y-axis, we have functional status. On your x-axis, we have an impact of surgery, that is time duration. So the upper one is your impact of surgery with a normal traditional care, and below one is your traditional surgery with an ERAS. As we can see, there are three parts in your upper graph. So that is pre-operative period, operative, and post-operative phase. So the pre-operative period with the pre-existing conditions, we are not going to do early and normal in traditional care. We didn't do much there. Any changes or any evidence-based interventions were done. The post-operative course was was seen here, as it can be seen here. It reaches to some particular endpoint. But there's some dotted line here, what is called optimum. So optimum is that you need to rehabilitate or prehabilitate the patient to an optimal level such that the course can of the during the intra or perioperative period decreases or it lessens the period of time. So with ERAS, as I told, the preoperative period, you add some interventions like chest physiotherapy, deep breathing exercises, and add nutrition, oral nutrition, enteral nutrition, add carbohydrating. So what is happening here, you can see instead of a flat line in the upper graph, there is an elevation of the event. Means the patient is trying to be reached an optimal level, which means you are going to increase the immunity or the nutrition of the patient so that the perioperative period, the stress response, you are going to decrease as less as possible. And during the operative period, we can see that the decrease in the slope of the graph is not as much as compared to your traditional care. And the normal pre-existing and the post-operative phase, we can see that in the first graph, the duration of the post-operative period is very long compared to that in your when you start with your traditional practice or you use your ERAS protocols. So all the changes that you're going to make in pre-operative period or operative period definitely will have an impact in the post-operative period, and you're trying to bring the patient near optimal level and early discharge, decreased length of stay, decreased complications, decreased readmission rates, and everything will be impacted by this change in practices what we are doing earlier. So this is of when ERAS is implemented, a graph I told, it shows an early recovery as shown in the graph. So this is because you are not altering the normal physiological state. Actually, it exceeds the normal illness. You're decreasing the endocrine metabolic response to your surgical stress response. So this is I doubt 3 different pre, intra, and post-operative graph. So the pre-operative period, you're going to do a prehabilitation. The intraoperative phase, you're altering your surgical and anesthetic maneuvers and minimizing downswing, and then mainly your surgical stress response. So effectively modulating the response to attenuate the impact of surgery may help to promote an early recovery and has been associated with decreased length of stay, complication rates, cost for the patients, and increased patient comfort and satisfaction, most importantly. So what are the interventions in ERAS? So interventions can be, as I told, pre-operative, operative, and post-operative. So pre-operative interventions include good nutrition, patient education, minimal starvation, oral carbohydrating, no mechanical bowel preparation. Operative interventions can be either doing antibiotic prophylaxis, good multimodal pain analgesia, goal-directed fluid therapy, maintain normal thermia, minimal tissue handling, decrease your operating time, and minimal access surgery. And post-operatively, decrease the chances of having post-operative nausea and vomiting, be giving prophylaxis intraoperatively, early removal of drains and tubes, nutrition, focus on mobilization, and ensure follow-up and discharge. So what are the surgical anesthetic considerations for us? So pre-admission, you need to have a counseling, good counseling, clear explanation as to what is going to happen during the hospitalization, explain the role of the patient, that is your food intake, oral nutrition supplementation, mobilization after surgery, and when he's going to be discharged. So what is the criteria for discharge? So that you should be able to take orally, you should be able to take oral analgesics, and able to be mobilized, and able to have disease-free, minimal alterations in normal hemodynamics. So these were the discharge criteria that was need to be explained to the patient before going for the surgery. Selective bowel pressure. Earlier, there was a tradition of giving enema to all the patients and prepare the patient for any colorectal or gut surgeries. So now the scenario has changed. Avoid mechanical preparation because they found that giving a bowel preparation can lead to decreased, altered fluid balance or decreased electrolytes or altered change in electrolytes because of giving the enema. So now their change is to add an antibiotic without bowel preparation, which will enhance your early recovery or gut motility later on. So 6-hour fasting for solid foods is enough. As per the NPO guidelines, liquids containing fat or particulate material and any clear fluids can be given 2 hours before the induction of anesthesia. So this is most important. Why this is most important is, see, earlier we used to tell the patients that you need to have a fasting of 6 hours for everything, no liquids to be taken before at least 6 hours prior to the surgery. But now the scenario has changed because if you're giving a clear fluids 2 hours prior to the induction of anesthesia, you are going to maintain the gut motility, acid-base balance is preserved, fluid and electrolyte balance, decreased insulin resistance or starvation period, that is going, the effects of starvation is going to be as less as possible. So how do you do the preparations? So if you, this is a scenario taken from one of the leading hospitals in Mumbai, that is Tata Memorial Hospital, how they follow. So on the morning of the initial surgery, case is posted. So the diet and fluids, you give 4 high energy protein drinks till the midnight and clear fuels 2 hours prior to the surgery, then fasting NBM. And later on, it is evaluated by a multidisciplinary team. If the patient is scheduled in the late afternoon, so you need not keep the patient fasting overnight and then wait for till his turn comes for the surgery. So you can give diet and fluids or any high drinks 6 hours preoperatively, early light breakfast at 7 or 6 hours prior to surgery, give fluids at 11:30 a.m. or 2 hours prior to the induction of anesthesia, and later on evaluate by the multidisciplinary team. So what is the preoperative carbohydrate loading, that is metabolic conditioning, that is being done there? So this is a newer concept in ERAS protocol. So that you need to give a traditional or something like carbohydrate 2 hours prior to surgery. What does it do? What does it mean? So clear carbohydrate diet before midnight or 2 or 3 hours surgery. What does it do? It decreases your preoperative thirst, hunger, anxiety, and significantly reduces your post-operative insulin resistance. You know that your surgery anesthesia is a catabolic state. There are high levels of insulin being secreted, and this leads to insulin resistance, and this causes your decreased your recovery period, and also along with their starvation, thirst, hunger, anxiety, all can lead to your delayed recovery phases and delayed gut motility, and everything can be prolonged. So if indicated, patient can also receive an antibiotic prophylaxis to reduce the risk of infection related to the surgical procedure. So the perioperative interventions include avoid pre-anesthetic additives or anxiolytics if possible, not always, depending on the patient. Nasogastric tubes in GI surgery, so definitely there is a role. So earlier in our institute, for any colorectal surgeries, if you are following an ERAS protocol, we put an orogastric tube and we remove that at the end of the procedure or at the evening of the day. So why? It can impair your return of gut function. It is not liked by many patients putting a tube in the nasogastric through the nase. Increase incidence of post-operative fever and reflux and pneumonia. Definitely, if it is a lower GI surgery, insert only if there is gastric distension. Upper GI surgery may be necessary. Pain control, the most important aspect, which we are mostly always concerned, and it plays definitely a major role in ERAS protocol. So always follow a multimodal opioid sparing management plan should be implemented. So you can, earlier there was a thoracic epidural anesthesia for any colorectal surgery. You place the catheter at T6 to T10 level and give local anesthetics with your additives. So that would cover your pain management. But now, over a period of time, so you change the modality or the approach of surgery, like going for less access surgery, minimal access surgery, like with the robotic or with your laparoscopic surgery, we found that thoracic epidural anesthesia is not as recommended for this person. You can get away with your ultrasound guide blocks like electric spine, tab blocks, or quadratus lumbar block and or rectus sheath blocks. So the main purpose of giving a multimodal analgesia, you decrease your pain, and also you are going to decrease your dosage of your anesthetic requirements. The most important, you decrease your stress hormone release and post-operative insulin resistance also. Short-acting anesthetic agents, definitely propofol. If you have a remifentanil, is good instead of using a fentanyl or morphine, which are long-acting, which can relate to. Along with that, if you want to use opioids, if you don't have any alternative modes of analgesia, so because you know that opioids can decrease your gut motility, and this can lead to your decreased delayed recovery and delayed discharge from the hospital. Short-acting inhalational agents is an alternative. Yes, if you have a TIVA, it's better than your inhalational agent. Multimodal anesthesia and regional anesthesia play an important role in ERAS protocols. Most important, one more thing is your perioperative fluid. What to be given? So whether you can liberal fluid, restrictive fluid, or your zero balance fluid. What is good for your or goal directed therapy, which is better for your in ERAS protocols. So there is nothing like that. So earlier there was a liberal fluid therapy, but they found that with liberal fluid therapy there was a volume overload, bowel edema, which causes delayed recovery, delayed post-operative ileus and recovery, everything. Restrictive fluid therapy, definitely it leads to your decrease in your mean arterial pressure, volume deficiency, hypovolemia, which can lead to other effects like acute kidney injury or myocardial injury. So There should be a balance between your liberal and restrictive. That is zero balance. Nothing but the concept of zero balance is nothing but at the end of your surgery, of any colorectal surgery, you should keep a balance of approximately 500 to 1000 ml of fluid. So, or the patient weight should not be more than 2.5 kg per day. So always use a goal-directed fluid therapy. Balanced chloride restricted to steroid solutions are always best. You're avoiding your high chloride. You're avoiding your high metabolic chloroacidosis. Colloids are of no use unless until they are required for hypovolemia or refractory to crystalloids. Always, I told positive balance at the end of surgery. Fluid overload or restriction is associated with delayed gut function and acute kidney injury. So you need to monitor your fluid, what you're giving, along with your urine output. If you have additional gadgets like your hemodynamic monitoring, you will have a guide to what is the required, what is the amount of fluid that can be and is need to be given to this particular patient. Maintain euvolemia and minimize salt and water overload during surgery. A balanced crystallized solution at the infuse at 1 to 3 ml per kg per hour. Maintain electrolytes. You can use your article-based analysis to know electrolyte imbalance. Intraoperative hemodynamics. Maintain a MAP or more than 65. Avoid hypotension for short duration. It can lead to adverse outcomes of myocardial or kidney injuries. Use vasopressors judicially. So earlier we had a notion that if your patient is going on a vasopressor, no, that means the patient is not good. So it's not like that. So you need to know that if when the patient is given adequate volume, even there is some, the Swank statics now, at a particular point of time, it will become refractory. So that is the point where you need to have an additional vasopressor, noradrenaline is a very good vasopressor, so that you can bring your MAP or more than 65 and maintain the perfusion pressures. In high-risk cases, you can have an objective measures of hypovolemia with like stroke volume, cardiac output, oxygen delivery, oxygen extraction, and mixed venous oxygen saturation, and dynamic indices of fluid response. All these can act as a guide to administer fluids. Surgical approach, as I told earlier it was open. Within now depend open procedures like either transverse incision or longitudinal incision definitely had an impact. So because of the prolonged mobility, delayed patient would go for because of pain and the patient recovery would delay because of your increase in pain, and chances of more gut motility, everything will be less. So always choose a minimal access surgery like laparoscopic surgery or a robotic surgery for colon surgery. Reduces the inpatient stay, lessens morbidity, and also the post-operative stay period is decreased. Avoid drain tubes and nasogastric tube in I told routine colonic resections, anything above peritoneal reflections, and consider short-term drainage for low anterior resections. Hypothermia definitely has a role. Hypothermia, delayed recovery, one of the most common complications of keeping your temperature as OT temperature less than 21 degrees centigrade. Always use warm blowers, warm IV fluids. Continuing warming during it doesn't end at the end of your operative period. Just continue till the post-operative during the post-operative period. Keep a temperature of more than 96.7 degree Fahrenheit. Monitor temperature. Hypothermia itself has its own risk factors of delayed recovery, infection, bleeding, and blood transfusion requirements. All these are detrimental, and it can prolong your course of patient stay in the hospital. Non-opioid analgesics, I told no, we are moving from opioid to opioid-free analgesia. So opioid-free analgesia, what are the other drugs which can be used? I told earlier, you can use ultrasound tab blocks, or facial plane blocks, or nerve blocks, wherein you can target the particular nerve roots with other drugs like your local anesthetics and decrease the use of opioids or opiates. So if you're not, other than that, what are the other modes of analgesia like intravenously? You can use short-term NSAIDs, which can avoid gastric irritation. Ketamine definitely as well preemptively given. Lignocaine infusions. Magnesium is a very good analgesic. It's a wonderful drug which is used in multiple other areas. For analgesia, you can either give a bolus or an infusion through the perioperative period. So the post-operative phase always start with the non-opioid oral analgesia, multimodal, either like blocks or with IV supplementations. Early mobilization, it should be encouraged out of bed, because the earlier the mobilization, the patient has a sense of well-being that his surgery is over and he's now able to sit or able to mobilize. So that gives a sense of well-being, and this helps in early recovery of the patients. And patients are always discharged after meeting a specific discharge criteria. Always engage in self-care to facilitate fast recovery. Prevention of nausea and vomiting is also the most important one, because it's one of the most common complications of any colorectal surgeries or after your lap surgeries, female patients and young patients. So you need to take care of this post-operative nausea and vomiting, because it's an unpleasant sensation. It delays gut function, affects motility, and has itself metabolic consequences. So either you can give prophylactic antiemetics like ondansetron 30 minutes around before the end of surgery, along with your dexamethasone. So it will decrease your chances of post-operative nausea and vomiting. Encourage early post-operative oral intake. So why the evidence practice say why you need to encourage your patients post-operatively early oral intake? Because it will facilitates your return of bowel function, stops intravenous fluids. If a patient is not naive fluids, is taking orally, it will help in mobilization and leads to faster recovery. And this reduces the post-operative morbidity and is not associated with any increased risk of wound dehiscence. Urinary catheters, you know that when the patient is recovered and is always is in the discharge room, IV fluids can be stopped and can be started on oral fluids. Clear fluids can be given at a rate of 1.75 liters per day, and should be encouraged as and when the patient is tolerated soon after the surgery. In case of your colonic or upper rectal recessions, you can remove a catheter within 24 hours. That decreases your chance of urinary tract infections. The risk may increase further with the urinary retention. In case of mid and lower rectal resection, catheter can be removed after 48 hours. Patient mobilization, early mobilization should, as I told, is encouraged. As earlier it was, patient should sit in the bed or lie on the bed, and whenever he is discharged to your ward, then only the mobilization was started. No, so we start in the ERAS protocol. The evidence-based practice tells that you can start mobilization on the day 0 at the evening of after surgery. Why? So bed rest, you know that it increases your insulin resistance, the muscle loss, and the risk of thromboembolism. You know that if a patient is lying on the bed every day, the chances of muscle loss is 1.5 to 2% of your body weight per day. It decreases muscle strength, pulmonary function, tissue oxygen delivery. So the aim in patient mobilization is to be out of bed for 2 hours on the day of the surgery and 6 hours a day until the discharge of the patient from the hospital. So some of the post-operative interventions I told earlier, which has to be started pre-operative, during a pre-rehabilitation period, that is your deep breathing and coughing exercises, incentive spirometry. When a patient is lying on the stretching his legs out straight, wiggling his toes and bending his feet up and down, all this could decreases a major role in shortening the length of stay and decreases the stretching, and resistance exercise is always beneficial. It is beneficial for the patient. So this chart tells you about what are the things that are going to be done on the day of the surgery and post-operative 1, 2, and 3 days. So clear fluids can be started on the day or the end of the surgery. Patient can be made to sit up in the bed and dangle his legs on the bed, and can make 10 times every hour you are waking, or that is your active heavy breathing and coughing exercises. Sham feeding or chewing gum. This is still a controversial. It's still not still in doubt whether this is going to affect or it will is beneficial to the patient. How? Chewing gum for 10 minutes or 3 to 4 times a day. It has been shown that it's like a sham feeding. You are trying to increase your peristalsis or gut motility, the return of bowel function as early as possible. But at the same time, some of the studies have found that this gum chewing can have detrimental effects. So still it's an equivocal whether to start with chewing gums or not. But the rest of the procedures are interventions that have been very useful and lead to early recovery of the patients. So these are two patients. One is doing the incentive spirometry of post-surgical, and one is patient sitting on the day of the day 0 with the drains there on a chair. So the one more term has come with the ERAS, that is enhanced recovery after surgery, that is ERA, that is enhanced recovery after anesthesia. So we know that anesthesia itself can cause a delayed recovery. So, and there are some interventions which has to be done, which can delay or the process of recovery. So some alterations or interventions which are modification of the drugs or procedures can lead to early recovery of patients from major surgery. So this is the last step ladder pattern of the ERA, where in the background you assess your risk, optimize your preoperative function with nutrition and your other interventions. Preoperatively, you Stratify. The risk stratification is done based on your scores, your POSM, lean index, lean index, cardiovascular risk calculator, walk test, CPET, cessation of smoking, antibody thromboprophylaxis, etc. Intraoperatively, you can change your protocols. I know I told earlier, short-acting drugs, multimodal analgesia, monitoring with hemodynamic monitoring, guiding your fluid administration, avoiding hypothermia, zero fluid balance or normal hemodynamic good glycemic control. So everything will add on or change the mode of course of patient during the intraoperative. Post-operatively, you can use your multimodal analgesia, opioid-free analgesia, then your laparoscopy, interperative local anesthetic infiltration, post-operative nausea, vomiting, post-operative delirium, one of the most common complications in major surgery. So you can take into consideration all these things and change your drugs that can be given intraoperatively. So nutrition as well is definitely an important role in ERAS. So how good? What do you want to give? Albumin? You want to start oral nutrition, enteral nutrition? It depends on your. So always a dedicated dietitian has to be there in your multidisciplinary approach, wherein you take care of the nutrition part and builds the nutrition. The most important thing, if the patient has a good nutrition, definitely the sale of the patient to perioperative will be as smooth and it will be as early as possible. So the discharge criteria, as I told earlier, it can be made when if Bills meets the following criteria: good pain control with oral analgesics, is able to take solid foods with no intravenous IV fluid requirements, is able to do, is mobilized, and all about the whole, yes, willing to go. Means like his patient is fit, I feel a sense of well-being that I'm able to do my things, if take care when I'm discharged at home, and I'm able to come back if anything is there. So will is more important in such type of surgeries. So this is a protocol what we had followed in our institute for the ERAS protocol for the open and surgeries. So to conclude that, so development of ERAS have been highlighted the importance of perioperative. It is now recognized as a subspecialty. So with the following of the traditional change in intervention and practices, there is reduced rate of complications, decreased readmissions, decreased length of hospital stay, early recovery, and which is good for the patient and also for the doctor who is treating this. So you're not going to, if you're not going to significantly reduce or change your perioperative physiology, but you're going to modulate and improve your patient outcome. Should always be familiar with the principles of ERAS, and last but not least, it's always a multidisciplinary approach, and every specialty has its own role, and a contribution from everyone will make a good team approach and better patient care. And these are my friends. Thank you.